Are you ready to elevate your expertise in pediatric critical care? Welcome to the Pediatric Critical Care Fellowship, a premier one-year online program designed to equip you with advanced knowledge and skills in managing critically ill children. Our aim is to provide you with high-quality educational materials and up-to-date pediatric critical care information delivered by a panel of highly qualified international expertise. Our professional panel ensures that the curriculum is current, evidence-based, and well-structured. This comprehensive fellowship is structured as 3 modules, 16 weeks each, with a total of 96 credit hours of in-depth training, delivered by a world-class faculty of international experts. Our curriculum ensures that you stay at the cutting edge of pediatric critical care. Your journey with us includes weekly lectures, MCQs, interactive case-based discussions, journal clubs, and virtual simulations, featuring the latest evidence-based pediatric critical care knowledge, plus a dedicated mentorship program to guide your learning every step of the way. From mastering mechanical ventilation and sepsis management to specialized training in mechanical circulatory support and neurological critical care, you will develop essential skills to manage critically ill children in any healthcare setting. Upon completion of the fellowship, you will enhance your credentials, advance your career, and improve your patient's outcome. With access to a cutting-edge smart learning platform, virtual case scenarios, and real-world applications, this fellowship bridges the gap between knowledge and clinical practice. Join a growing community of critical care professionals who have transformed their careers with this fellowship. Don't miss this opportunity. Are you ready?
Hello, everyone, and very nice seeing all of you today with this international gathering. Try to help our patients. Our aim of these webinars and this online education is to improve our patient outcome and our standard of care. So thank you again for joining us today. And we have very special webinar today, and we have very special guest speakers. As you can see here, we have gathered a lot of expertise from all over the world, from USA, Saudi Arabia, South Africa, and more, to give you the up-to-date information how to manage your children, your vulnerable patients, how to best manage them to improve their outcome. So every single physician, including adult and pediatric physicians, they deal with septic patients. And today we will give you some tricks and guidelines how to deal with these septic children. I'm going to give you some brief introduction about the webinar and our fellowship. Then Dr. Asma Salo from South Africa is going to give you some samples of the fellowship. Then Dr. Raed Sadiq from Saudi Arabia is going to give the first talk about pediatric sepsis, focusing on clinical based case discussions. Then Dr. Turki Al-Atibi is going to handle the question and answers with Dr. Raed Sadiq. And our guest speaker is Dr. Udrea, who is going to give very nice introduction about pediatric sepsis in resource-limited settings. This is his main interest, to help children in the developing countries and resource-limited settings to improve their outcome. Then Dr. Michael Kamari is going to help Dr. Udrea to answer the challenging questions and inquiries. Then we'll end up by having closing remarks by Dr. Raed Sadiq. Again, great speakers. And I'm going to give you a brief introduction first about our fellowship. Our fellowship is very unique, and we structure this fellowship to accommodate you and to adjust to your need all over the world. We have hundreds of fellows are joining our e-learning, and we structure this pediatric critical care fellowship as 3 modules. Each module is 16 weeks. So it's 1 year of training accredited by the American Association of Continuing Medical Education. It includes lectures, journal club, clinical-based discussion and clinical case scenarios, MCQs, and webinars. And we have very nice international board from all over the world, from Pakistan, United States of America, Canada, South Africa, Egypt, United Kingdom, Saudi Arabia, and more. And because we know that our fellows' retention rate is very low when it comes to teaching through the lectures and reading, we don't want you to be passively involved in the education, but we are planning to engage you in the educational process, and you would be very active throughout the whole year. We'll have discussion, we'll have practice sessions, and we'll allow you also to teach. So at least we'll help you to improve this low retention rate with the lecture and reading and go up to about 30 to 70% using audiovisual demonstration, discussion, and teaching. Again, this is bi-directional educational fellowship. It doesn't depend on one-way education through webinar or seminar. It's a dialogue rather than monologue. And you will have hundreds, if not thousands, of question and answer, evaluation and assessment. We'll teach you how to do critical thinking and appraisal. And again, it's wholly online, and we'll be gathering once every month. But other than that, all the educational materials are uploaded in the smart platform that you're going to have username and password, and all scientific materials will be educated throughout this smart platform. You will have the freedom to navigate throughout these scientific materials, complete your tasks and assignments on weekly basis, and you just need to turn in your assignments by the end of each week. After you listen to the recorded lecture, you answer the MCQs, you read the journal article, and you go over these clinical case scenarios. All of our fellows' activities and assignments are monitored in the platform, and there will be weekly quantitative and qualitative evaluation and assessment, not only based on who is going to answer the question correctly, but also on the engagement and the involvement and active participation throughout the whole year. Here is Module 1, syllabus and curriculum. We're going to start with causes classification criteria of shock. We'll focus on nutrition in critical ill patients, point of care ultrasound in acute settings, and we'll have 1 month education for infections, various kinds of infection. Module 2 is going to focus on specialized topics and some system affection, starting with respiratory critical care, cardiovascular critical care, then critical care nephrology. Module 3 is dedicated for neurocritical care education, traumatic brain injury, endocrine and metabolic disorders, and oncologic emergencies, and gastrointestinal urgencies and emergencies. Upon completion of this program, you would anticipate that you will be an expert in the pediatric critical care field, and you're going to be graduate to a trainer and mentor level, and you're going to receive American accredited certification from the American Association of Continuing Medical Education. Let's go back to our webinar today. Without further ado, I'm just going to introduce our first speaker, and our first speaker is Dr. Salo asthma. She is an expert pediatric physician from South Africa, and Dr. Asma Salo has been practicing for over 10 years. She worked in the Red Cross War Memorial Children's Hospital in Cape Town for over 3 years. Now she relocated to Taif, Saudi Arabia, and she's one of few experts in the field of cardiac critical care, ECMO training, and also mechanical circulatory support. In addition, she gained a great experience from Canada and other training program in organ transplant and also in patients with complex congenital cardiac repair. Without further ado, I will let Dr. Asma to give the first presentation. And the first presentation today will be just samples of our pediatric critical care fellowship.
Good day, everybody. Welcome to this webinar from the World Institute of Critical Care and Emergency Medicine. And thank you very much for joining us today. I am Asma Sallu. I'm a pediatric intensivist, originally from South Africa, with quite a few years of experience both in South Africa and abroad. And I've recently relocated to Taif and Saudi Arabia. I'm going to share with you in this presentation some of the sample materials for the Pediatric Critical Care Fellowship. So firstly, we have a very diverse, experienced group of board members who have prepared a number of different sessions for you through the course of the fellowship. As you can see, there's the different board members up on the screen from various different parts of the world, including North America, Europe, Africa, and the Middle East. And I hope you will enjoy engaging with us, and we would be learning from each other. So this is a one-year online program, and it provides a certified comprehensive knowledge and skills in pediatric critical care medicine. What's unique is that this flagship fellowship is offered entirely online and is structured into 3 modules of 16 weeks each, with a total credit of 96 hours. The fellowship is accredited by the American Association of Continuing Medical Education. Like I've said, the fellowship is divided into 3 modules. Each module takes place over 16 weeks, and you can see all of the different topics that are covered in the different weeks. It's further subdivided into 3 or 4 sections with live sessions monthly, and each week dedicated to different critical care topics. And you can see as it progresses along, the intensity and nature of the topics increases. So there's various different methods that we use in terms of learning. And it's not just a passive process where you just get to watch webinars, but they're weekly online lectures with the monthly webinars that are interactive. There's lots of case-based discussions and virtual simulations. And also the advantage of this fellowship is that they're self-paced modules together with quizzes and assessments. So you actually have to actively participate. And weekly journal clubs happen with state-of-the-art manuscripts. So there's some expectations of you weekly, and each week you're expected to complete the set tasks for the week before moving on. So there's a lecture, and that's followed by MCQs, and the lecture is usually about the topic of that week. And the MCQs are designed to test your working knowledge from that lecture. That's followed by a journal club, also together with MCQs, to test your comprehension of the journal and hopefully to try and consolidate that information. And then there's case-based scenarios to try and apply some of the knowledge that you may have gained from the lectures and the journal club. So in week 5, I'm going to cover the sepsis module with you. And what's going to follow in the next few slides is a sample of some of the materials that you can expect for the sepsis module. So firstly, we'll start off with the lecture, and it's a lecture on pediatric sepsis. We start off by talking about the history of sepsis and our understanding of sepsis over the years. Why is sepsis important and what is some of the epidemiology and importance and morbidity and mortality of sepsis, because a lot of that guides how we deal with different medical conditions. We'll then talk in detail about the different definitions of sepsis and how these definitions have evolved over the years in pediatrics. And then you'll hear about the Phoenix sepsis score, which is the latest sepsis definition. You'll also get an introduction to that in the webinar today. And then we touch on the pathophysiology of sepsis and that interaction between microorganism and host and the balance between the two. We also look at the different sepsis phenotypes and then end off with the surviving sepsis guidelines and an in-depth look into managing sepsis in pediatric patients. So that's an overview of the lecture, and that's followed by MCQs. And if you look at the MCQ based on the lecture, this is one of the sample MCQs, and if you read it there with me, it's got a stem that says, according to the surviving sepsis guidelines for children, which of the following is the most appropriate initial fluid resuscitation for septic shock? You have 5 options. You obviously then choose the option, and once you've chosen the answer, once you've chosen an option, it will then generate an answer and tell you which answer is correct and why different answers are incorrect. So as you can see, response C was the correct response, and there's an explanation as to why that was the correct response and why the others are incorrect. So you're learning as you're being tested as well. This is then followed by a state-of-art manuscript. As you can see, this comes from 2023, and it's a summary of current definitions and management recommendations. You get a PDF of the journal, and you get to download it, keep it, and have it as a resource as well as read it. And that's followed by MCQs, again, testing some of the knowledge that comes out of that article. So according to this article, what is the most important factor in improving outcomes in pediatric sepsis? Again, there are 5 options. Once you've chosen an option, you will then get the correct answer and explanation as to why the answers are correct or incorrect. Then go into case scenarios. So for example, in this case scenario, we have a 6-year-old boy who's been previously healthy, presents to the emergency department with fever, tachycardia, altered mental status. He has delayed capillary refill, blood pressure of 85/50. His lab results show an elevated lactate and mildly elevated creatinine. Of note is that he fell at school 5 days ago and has a swollen ankle but no open wounds or abrasions. The emergency department team is concerned about septic arthritis. The question is, what is the most appropriate initial step in the management of this patient? Again, you have 5 options. You can choose one, and then it gives you the answer with an explanation as to why each of those points may be correct or incorrect. So that's essentially the weekly overview of the content contained in each module of the week. And so some of the goals of our fellowship program are to provide advanced training in the management of critically ill pediatric patients. We would like to develop expertise in pediatric critical care physiology, pharmacology, as well as procedures, and to also foster skills in an MDT environment together with teamwork, communication, and family-centered care, and also to prepare fellows for leadership roles in pediatric critical care, ultimately to improve the standard of care, clinical practice, and outcome for critically ill children. You can scan the QR code and it will take you to the fellowship landing page, and the link is also above there. And you can find out more about the fellowship. A lot of what I've showed you in terms of the modules and the handbook is there on the fellowship page, and there's also a link for registration. We look forward to you joining us in this Pediatric Critical Care Fellowship. Thank you very much.
Thank you, Dr. Asma, for this nice presentation. Now we'll go to our scientific presentation. I'm Dr. Turki Al-Utaibi, a pediatric intensivist from Saudi Arabia. I'll moderate for the first speaker. It's my pleasure. Dr. Wright, he's a friend of mine and colleagues. He's pediatric intensive care consultant in King Fahd Medical City and second health cluster in Riyadh. And he is also the head of division of PICU in Al-Yamama, MCH Hospital in Riyadh. And he's also senior lecturer at Imam Muhammad ibn Saud University in Riyadh. He will talk about pediatric sepsis clinical cases scenario. Welcome, Dr. Wright, and you can start your presentation.
It is my pleasure to be with you in the coming 20 minutes talking about sepsis in pediatrics and clinical scenarios. Are we still missing early signs of sepsis in children because we still rely on outdated criteria like SIRS criteria? How about the limitation of SIRS criteria, the new introduction of sepsis 3 version and its limitation, the use of SOFA score, PEACE SOFA score, and lastly, the amazing updated Phoenix sepsis definition and criteria. So we will walk through all these interesting subjects. Despite decades of research in sepsis, especially in the adult literature, which started in 1991 with the first international consensus definition, it introduced the term of systemic inflammatory response syndrome, SIRS. And sepsis is SIRS with confirmed or suspected infection, and they use the redundant term, which is severe sepsis equal to sepsis in addition to organ dysfunction. However, septic shock, they defined it as sepsis with induced hypotension despite fluid resuscitation. Then in 2001, the sepsis 2 definition, it used the same SIRS criteria. However, it broadened the diagnostic criteria like the lactate and CRP, and they enforced the same sepsis continuum, and they emphasized on the early goal-directed therapy. However, for the pediatric sepsis, the first criteria was published in 2005 by the Pediatric International Sepsis Consensus Congress, and it used the same adult SIRS criteria with 2 or more criteria out of these 4, but one of them must be abnormal temperature or leukocyte count. On these 4 criteria of SIRS is the temperature more than 38.5 centigrade or less than 36 centigrade. Tachycardia or bradycardia in infants, tachypnea or the use of mechanical ventilation, and lastly the abnormal leukocyte count or band count more 10%. And because of the unique different age group in pediatrics, so they have age-specific vital signs and laboratory variables as we see in this figure. So the column 1, it includes the obligatory, one of them is the temperature and the leukocyte count, and it could be hypothermia, not necessarily fever, and it could be leukopenia, not necessarily leukocytosis, and bradycardia, especially in infants. And we should have at least one from this column 2, which is tachypnea, tachycardia, or hypotension. So the Pediatric Sepsis Consensus Congress in 2005 used the sepsis 2 version, and they specify infection as suspected or proven infection caused by any pathogen, not necessarily bacteria, can be viral, fungal, or a clinical syndrome associated with high probability of infection. And sepsis is SIRS in the presence of infection. Severe sepsis, it is a redundant word or terminology that signifies sepsis plus one of the following: cardiovascular dysfunction, ARDS, or 2 or more other organ dysfunction, and septic shock is sepsis with cardiovascular organ dysfunction. So if we try to apply these criteria, SIRS criteria on the coming scenario, this is 8-year-old girl presented to the ED with vomiting, generalized abdominal pain and tiredness, no history of fever, cough, diarrhea, or other symptoms. The whole family has had a flu in the past week, and all 3 children were absent at home from school because of fever, myalgia, diarrhea. On the ED, she was afebrile with tachycardia 138 and tachypnea of 40. Oxygen saturation was 99 and her blood pressure was normal. Glasgow coma was 14/15. She was tired appearing but arousable and alert in addition to be oriented. She had a dry mucous membrane, clear lungs but tachypnic. She is tachycardic with dry, cool extremities, capillary refill delayed. However, the abdominal examination is normal. If we apply the SIRS criteria, so she has tachycardia, tachypnea, and there was leukocytosis. However, this is the case of DKA with severe hyperglycemia, metabolic acidosis. So we can label sepsis for DKA cases or bronchiolitis or other common pediatric diagnosis. The other clinical scenario is 8-day-old girl presented to the ED with poor feeding in the last 24 hours, progressively poor color, and difficulty breathing over the last few hours. On the ED assessment, she was gray, flabby, moaning, just arousable, grunting, tachypnic with recession and nasal flaring, in addition to oxygen saturation, room air 85. She had unrecordable blood pressure with weak femoral and brachial pulses and delayed capillary refill with tachycardia with abnormal temperature. She was acidotic with lactate of 10. So this is her X-ray, showed cardiomegaly with congested lungs. Although we should treat her early, but her diagnosis simply was cardiogenic shock due to duct-dependent systemic circulation, hypoplastic left heart syndrome. So there is a clear limitation of the SIRS criteria with very low specificity. It can label sepsis and SIRS with condition beyond infection like trauma, burns, common pediatric diagnosis like bronchiolitis or other inflammatory process. Also, it is overly sensitive and it can miss some patients with true sepsis, especially early in the disease course, who may not meet the threshold of like abnormal temperature. It was expert-based criteria, not globally validated, especially in limited resource setting. So it has limited applicability. In addition to limited prognostic value, it doesn't really reliably predict severity of the illness or the patient outcomes, such as mortality or the need for intensive care. This is one of the recent article even mentioned that SIRS criteria is a poor in even identifying serious infection in febrile young infants. It is a prospective cohort study in the ED with infants less than febrile infants less than 90 days. They enrolled 311 patients and they found the performance of SIRS criteria for predicting serious infection was poor. So there was a big move in the third international consensus conference for sepsis and septic shock, which is the sepsis 3 version in 2016. It introduced the new concept of life-threatening organ dysfunction, and they differentiate sepsis from uncontrolled infection. And they found that it is mainly due to dysregulated host response to infection. And they identify sepsis by using what is called sequential organ failure assessment, SOFA, by at least 2 points with suspected infection, and they remove the severe sepsis terminology. I used only septic shock, which identified sepsis with vasopressor used to maintain arterial blood pressure above 65 or higher, and serum lactate more than 2 in the absence of hypovolemia. These criteria were not developed for pediatric data nor validated or adopted for children, and it was intensivist based task force mainly in high resource countries. And there was many hard working to modify the SOFA score and use the Q-SOFA, which is the quick SOFA to be used in the emergency department, and the pediatric SOFA score. And they use in the sepsis 3 version 6 organ dysfunction, respiration, coagulation, hepatic, cardiovascular, CNS, and renal, and this is the P-SOFA, which depends on the SF ratio, not necessarily to have arterial blood gas, and use the platelet, bilirubin, and mainly the use of vasoactive medication. So if the score is equal or more than 8 is the optimal cutoff for predicting life-threatening organ dysfunction in pediatric sepsis, and should be done within 24 hours. If we move to the last case scenario, this is a 9-month-old healthy girl healthy before but unvaccinated, brought to the ER with cough, difficulty of breathing, fever, in addition to poor oral intake for the last 10 days. There is no GIT upset symptoms, no urinary symptoms, no skin rash, no mucocutaneous symptoms. The mom reported her mom reported multiple ER visits in the same illness because of fever and cough. She was given every time nibs in the ER and discharged an oral antibiotic. In the last ED visit, unfortunately, suddenly collapsed with abnormal movement in addition to cyanosis and desaturation. This movement was aborted by rectal diazepam, and she was in the post-ictal state with anterior fontanelle at 11. She was tachycardic with heart rate of 150 to 180. Capillary refill time is a bit prolonged. Maintaining blood pressure, however, the lactate was 6 and her temperature was 39.2 centigrade. She was connected to simple face mask, 5 liter, monthly distress with crepitation, and she was tachypneic with saturation improving on the simple face mask. Her abdominal examination was normal, no skin rash. Her initial lab was basically normal apart from high lactate, leukocytosis, and mild metabolic acidosis. So in the ED, they give her the NIPS and maintaining her oxygenation. They give her a fluid bolus of 20 ml per kilo crystalloid. Her blood pressure was normal, however, the heart rate not much changed, and they did a full septic workup, including lumbar puncture, which came to be normal, and they start her on vancomycin, ceftriaxone. However, they admit her to the general pediatric ward as sepsis. After 2 days in the ward, the PICU was consulted because of the increased oxygen demand and difficulty of breathing and increased work of breathing. However, when she came to the PICU, she was in severe distress. She was connected to high-flow nasal cannula with FiO2 100%. Unfortunately, she did not make it, and within 2 hours, she was intubated and connected to high settings of conventional mechanical ventilation, and her influenza PCR came to be positive. Unfortunately, she was having refractory hypoxemia. We used high frequency in addition to inhaled nitric oxide, and we consult ECMO surface early due to the refractory hypoxic respiratory failure. After fluid resuscitation of 60 ml per kilo, she was started in epinephrine, and unfortunately, in the coming few hours, she was having AKI and acute liver injury. If we compare the P-SOFA score in the ward for this patient, was 2. However, when she came to the PICU, it was 6, depending on the Glasgow coma and SF ratio and the cardiovascular dose. So Unfortunately, she was having multi-organ dysfunction, severe ARDS, circulatory failure, AKI, acute liver injury, and DIC, and she was having high mortality and unfortunately expired. So we discussed this case with our colleagues in the pediatric ward and the pediatric ED. We were having concerns about multiple ER visits, some delay in PICU consultation if it is there, and we introduced the concept of early ECMO consultation for such cases. However, such cases, when reached to such severity, the mortality is very high. How about limitation of sepsis 3 virgin? Although it has the advantage of the introducing the terminology of organ dysfunction, it potentially may delay the diagnosis compared to the old SARS criteria to detect sepsis earlier in children, and this is time sensitive in pediatric age group. And as all we know that children often compensate physiologically for longer period before they crash suddenly, as our patient making the SOFA score, either the actual SOFA or quick SOFA, with low sensitivity in the pediatric population to detect sepsis and predicting the mortality. And also the sepsis 3 was mostly the task force of in the intensivist from the high resource setting, not including the low resource setting. So this is the quick sepsis, pediatric sepsis timeline. Because of all these challenges, in 2019, the SSCM asked for task force to validate a pediatric specific sepsis definition, which should be globally accepted and validated in high resource setting and low resource setting. And they came up with the new amazing updated Phoenix pediatric sepsis definition and criteria using 4 organ dysfunction and a specific Phoenix score for pediatric sepsis. So just a quick touch on Phoenix criteria, and Dr. Uderia will go through more deeper insights for this subject. So actually Phoenix is the historical and mythical bird from the Greek culture, which is a bird with endless life, and it has the power against death. So the pediatric Phoenix criteria define sepsis as infection with life-threatening organ dysfunction using 4 organ system module, which are the neurological, cardiovascular, respiratory, coagulation, and we should have a Phoenix sepsis score of at least 2 points in these 4 organs. And the septic shock is sepsis with cardiovascular dysfunction indicated by at least 1 cardiovascular point in the Phoenix score, including hypotension, lactate more than 5, or the need for vasoactive medication. And this is the Phoenix scoring system using respiratory 3 points, cardiovascular 6 points, coagulation 2 points, neurological 2 points, and it is from 1 to 3 points. So the take-home message that the updated pediatric sepsis focus on the organ dysfunction, not the SARS organ dysfunction, using 4 system module in Phoenix had a similar performance for the 8 organ module, and it should be used in the first 24 hours in suspected infection. It is complementary to your clinical judgment, but does not replace it. And it is merely a diagnostic tool, not used as a screening tool. So the SARS-based tool may still have a critical role to detect early detection of early signs of sepsis. And I will keep the floor for Dr. Uderia to have more fruitful insights about the pediatric sepsis criteria. Thank you.
Thank you, Dr. Wright. Very nice presentation. And it answered many questions that our colleagues in the audience asked. We'll go for some of them. And there is also others. Maybe a second speaker will answer about the limited resources, how to deal with the sepsis. So first question, what's the criteria for pediatric sepsis about 𝐂𝐞𝐫𝐢𝐭𝐞𝐫𝐢𝐻 SOFA score still relevant? You talk already about it. That's mainly in the adult. What is the main clinical and laboratory criteria to identify sepsis, especially early?
Okay, thank you for this question. Actually, as we mentioned, to diagnose sepsis, the best is to use the updated Phoenix criteria, to use organ dysfunction, and it is important for diagnosis and not to over-diagnosis. However, in some resource-limited area, maybe we need still to use the SERG criteria because of the lack of some important labs. So we should go quick view over the 4 organ module, the respiratory, cardiovascular, the coagulation, and the CNS. And for coagulation and CNS, we can use for the coagulation only platelet. No need to have INR or the fibrinogen or D-dimer. And simply the Glasgow coma will be sufficient. So I think this is the best, and we will have it in the closing marks more.
Okay, very good. Doctor, also, you know, in septic shock, there is association with multi-organ dysfunction syndrome of organs. What is the parameter are used to assess those organ dysfunction?
Okay, this is a very excellent question. Actually, we have different scaling system. If we diagnose sepsis, you know, from the 4 module, we can go to the renal and liver and other important organs. So from there, we can depend on like serum creatinine, we can, and the liver, we can depend on the bilirubin level. And there is also very important thing, maybe there was no time to mention that, especially in our case or any case with infection and the development of multi-organ failure, especially if there is pancytopenia with fever, we should keep in mind what is called secondary HLH or macrophage activation syndrome. And this one should be tackled with clinical suspicion. We should send for serum ferritin, and we should start with at least the first line treatment like IVIG.
Very good. There is there is one question here about in the management of pediatric sepsis, how to overcome between abuse or delay of using the antibiotics. Urgent administration, empirical antibiotics, one of the gold standard to be used, and how to overcome the abuse of using the antibiotics.
I think it depends on the setting. For example, in many settings, like in our settings, we have, you know, we have like infection disease on call. We have many facilities. So I think as early as possible, you need, if you suspect sepsis, you need to start in the golden hour, sometimes even before culture. Even if you were not able to take culture, you should start the antibiotics. And a big bottom line, that start antibiotics even if there is very minor suspicion, and then we can de-escalate later. However, maybe the misdiagnosis is more serious than the overdiagnosis.
Okay, thank you very much, Doctor. And now we'll move to Prof. Michael Canary to present himself and the second speaker. And we finished from first session. Dr. Michael, your turn.
Thank you very much. Thank you very much. I'm happy to have the opportunity to present my friend, Dr. Odira Nwankwo. Dr. Nwankwo received his medical degree from the University of Nigeria in Enugu. He received an MPH from the University of Lagos, a second MPH from Johns Hopkins University in Baltimore, Maryland. He completed a PICU fellowship at the University of Maryland in the United States and is currently a faculty member in the pediatric ICU at Nemours DuPont Hospital for Children in Wilmington, Delaware, as well as an associate professor of pediatrics at Jefferson University. Odira has practiced pediatric critical care and emergency medicine around the world. He's a recognized leader in pediatric global health and sepsis. So I'm happy to have him with us today.
Thank you so much, Dr. Canary. I'm so happy with your introduction, and I think it's a setup for you guys to expect so much. I hope I'm able to meet up with your expectation. Good evening, good afternoon, or good morning, wherever you're listening to us from. My name is Odira Nwankwo, and I'm going to be talking about pediatric sepsis in resource-limited setting. I'm actually quite glad that Dr. Sadiq had actually mentioned most of the things that I'm going to be talking about. Let's see. Where am I not able to? Okay. All right. In full disclosure, I do not have any conflict. The only disclosure I have to make is that I speak fast and I have a little accent. So just bear with me. My outline will be to talk about the 2005 First International Pediatric Sepsis Consensus Conference. And I'm going to also mention the 2016 Sepsis 3 definition. And then we zero into the international consensus criteria for pediatric sepsis, which is actually the theme of the webinar. And very importantly, we'll move into management of pediatric sepsis. We're going to, kind of talk about it a little bit. And as we talk about that, we're also going to mention the 2020 Surviving Sepsis Campaign Guideline. So the 2005 International, this is the first International Pediatric Sepsis Consensus Conference definition. But just as all of us know, most of the things in medicine starts from adults, and then it will gradually come down to pediatrics. So this first International Pediatric Sepsis Consensus Conference definition of sepsis actually mirrors the 1991-92 Sepsis 1 and the 2001 Sepsis 2 definitions. And I call those definitions the SARS criteria. That's what they used. And for this first International Pediatric Sepsis Consensus Conference, it was mainly based on expert opinion. And they defined sepsis as suspected or confirmed infection in the presence of SARS. I'm not going to go into what SARS is. I think you guys know that. And then they defined severe sepsis as sepsis with cardiovascular or respiratory organ dysfunction, or dysfunction of at least two other organ systems that are not cardiorespiratory. And they defined septic shock as sepsis with hypotension or need for vasoactive medications or evidence of impaired perfusion despite resuscitation with at least 40 mL per kg of IV fluid or even more. Then what about, I can't move the slides. Can you guys hear me? I can't move the slides. I don't know why.
We can hear you, Odira.
Yeah, I can't move the slides.
Can you stop share and reshare it again?
Yeah, let me stop sharing and share it again. Okay. I think it was moving a little bit before. Okay, where did I stop? All right, so I was giving you the 2005 First International Pediatric Consensus Conference definitions of pediatric sepsis. And I kind of mentioned that these things, that it mirrors the sepsis 1 and the sepsis 2 from adults. And then the sepsis trait, it is important that I actually mention that. Like I said, most of these things start from adults and then it will come down to pediatrics. So the sepsis trait was in 2016. It was the 3rd International Consensus Conference for Sepsis and Septic Shock. I call this the SOFA criteria. This is an adult. And sepsis trait is so important because what it did was that it differentiates sepsis from uncomplicated infection. And that's very important for us to note. And how did they define sepsis? They define sepsis as suspected or confirmed infection in the presence of a life-threatening organ dysfunction. Very important. So it has to be a life-threatening organ dysfunction. And life-threatening organ dysfunction is demonstrated by an increase of at least 2 points on the SOFA score. I'm going to show you what the SOFA score is all about on the next slide. And they defined septic shock as sepsis with cardiovascular dysfunction. And the cardiovascular dysfunction here is defined as sepsis with vasopressin need to maintain MAP of greater or equal to 65, or serum lactate of greater than 2 in the absence of hypovolemia. So what is very important about sepsis trait? They removed completely the SARS criteria, and they also removed severe sepsis. They thought that the severe sepsis definition is becoming redundant and doesn't add so much value. Now, why is it that we don't use it in pediatrics? We do not use it because there was no pediatric data that was used for this, and then it was not validated in children. That's why we don't use it. Then this is what your sequential organ failure assessment score is, the SOFA score. This score is usually done within the first 24 hours of patient exposure to the hospital. So it could be in the ED, it could be on the floor, it could be in the ICU. And the SOFA score looks at 6 organs. It looks at the respiratory, the coagulation, the liver, cardiovascular, CNS, and renal. And the range of scores starts from 1 to 4. If we pick up the respiratory and look at the PF ratio, if the PF ratio is less than 400, you score 1. If it's less than 300, you score 2. If it's less than 220, you score 3. And if it's less than 100, you score 4. Now, if you take up another one, probably like coagulation, if the platelet is less than 150, you score 1. If it's less than 100, you score 2. If it's less than 3, you score. If it's less than 50, you score 3. If it's less than 20, you score 4. Now, like I said earlier, that anything that is in medicine starts from adults and then it will permeate into pediatrics. So the 2024 International Consensus Criteria for Pediatric Sepsis and Septic Shock, what we call the Phoenix criteria that came out last year, actually mimics sepsis trait in adults. And they define sepsis here as confirmed or suspected infection in the presence of a potential life-threatening organ dysfunction, but of just the respiratory, the cardiovascular, the coagulation, or the neurological system. So it's talking about just 4 organ systems here. And the life-threatening organ dysfunction is demonstrated by at least 2 points on the Phoenix score. So you will now begin to see a pattern that this is actually what the sepsis trait does in adults. The only difference between our international consensus criteria for pediatrics and the sepsis trait is that in sepsis trait, it talks about 6 organs. In the Phoenix sepsis criteria, it talks about just 4 organs. And the life-threatening organ dysfunction is demonstrated by at least 2 points in the Phoenix score. In the sepsis trait, it talks about the SOFA score. So those are just the differences. But otherwise, it is the sepsis trait that was modified to give us our 2024 International Consensus Criteria for Pediatric Sepsis and Septic Shock. Now, how does it define septic shock? It defines sepsis shock as sepsis with cardiovascular dysfunction that is indicated by at least 1 cardiovascular point on the Phoenix sepsis score. And that would include 1, that's severe hypotension for age, or blood lactate that is more than 5, or need for vasoactive medication. Now, I'm going to spend a little more time to discuss the Phoenix sepsis score, more so because my topic is about resource-limited setting. Remember what I told you earlier, that the Phoenix sepsis score includes just 4 organs: the respiratory, the cardiovascular, the coagulation, and the neurological. And the scoring system starts from 0 to 3. Now, if you look at the respiratory, you can use your PF ratio. You can also use your SF ratio. If your PF ratio is greater or equal to 400, you score 0. Now, if you look at your cardiovascular, it looks at 3 main elements. It talks about the vasoactive medication, the lactate level, or your mean arterial pressure. That is your MAP. Then if you look at the coagulation system, it looks at 4 major things. It looks at your platelet, your INR, the D-dimers, or fibrinogen. And then your neurological is almost the same. You're looking at glaucoma scale. Why is this important? The Finnish sepsis score and definition is international. It is international because all you need to define your sepsis is an increase of at least 2. And it doesn't matter where you are. If you are in a low resource setting that you don't have an arterial blood to get your PaO2, you can use your SF ratio. It's just your SATs and your FiO2. If you're also in an environment where you don't have access to vasoactive medications and you don't have the resources to do your lactate, that's okay. But I would imagine that most of the regions in the world are able to measure blood pressure. So you can just use your mean arterial pressure to get your scores. And for coagulation, you do not necessarily have to have your INR. You don't have to. If you have the resources to do that, very good. If you don't have, that's okay. You can use your platelet alone. But if you have resources to do INR, very good. If you can do your D-dimers, that's good. If you can do your fibrinogen, that's also okay. But you do not have, and that is the essence and one of the good benefits of our new definition based on the Finnish sepsis score. The glaucoma scale is just a physical exam. You don't need any resources. You just do your exam and you're able to score. Then if you look at the lower end of the table, you will see that it makes that emphasis again that this Finnish sepsis criteria is define sepsis as suspected infection and Finnish score of 2 or greater than, or equal or greater than 2 points. And septic shock is sepsis with greater than 1 cardiovascular point. Very, very comprehensive and again, international. However, despite the fact that the aim of the pediatric Finnish scoring system is to make it international so that it's able to be used anywhere, low resource setting, high resource setting. Sefula and her group, they were really concerned that despite the fact that the Finnish score is meant to be international, they got some kind of worry and challenge that the Finnish sepsis score consists of point system that includes several diagnostic tests and therapies that are not readily available in the low resource settings, such as measuring lactate, such as measuring advanced coagulation markers, and also access to vasoactives. What I want to say is that their points are quite valid, but remember what the Finnish sepsis score shows us. It has about 13 scores, and all you need is 2. So even in low resource setting where you don't have the resources to measure serum lactate, you cannot measure all the coagulation markers, and you don't have access to vasoactives, it still does not matter. You should still be able to use all the other systems and be able to get your scores. Now, let's go to what is really important, because it does not matter what definitions that we are using. What is most important is how do you manage septic shock? How do you manage sepsis? Just like anything, any medical condition, and this is what I teach my trainees, if you remember your ABCD, you should be fine. So it doesn't matter what is happening to the patient. It doesn't matter how you have defined your septic shock. The most important thing is your management. ABCD, A is your airway. Make sure that you position your airway, you stabilize your airway, and then make sure that the patient is breathing, and then supplement oxygen if you need to. And then the beautiful thing about working in the ICU also is that you could be doing one thing and delegate duties for people to help you. You could be trying to stabilize your airway and ask somebody to help you get a vascular access, and then you start your cautious fluid replacement. Very, very importantly, you're starting your D, which is your medications, you're giving your antibiotics, you're also giving your vasoactives. Now, let's go a little bit deeper into what you do. In the first hour, I call this the golden hour. Very, very important. The moment you make that decision, you need to move fast. Remember part of the case presentation that Dr. Sadiq gave, that if it was realized early and one or folks did move fast in that first hour, maybe that child would have lived. So what do? Fluid administration. It is so important. If you are in a low resource setting, check and see if there's any sort of cardiovascular compromise. By that, we mean hypotension. If there is no hypotension, do not give boluses. Please do not give boluses. Just start with maintenance fluid. I'm going to talk briefly also about what the Surviving Sepsis Campaign International Guideline says. But remember that no cardiovascular compromise, no fluid boluses. You're starting with your maintenance fluid. However, if there is cardiovascular compromise, that the patient is in shock, you can start with aliquots of your crystalloids. It is actually advised that you start with 10 cc's. You can go up to 20 cc's. But what is super important is reassessment. After every fluid bolus that you have given, reassess for fluid overload. You're looking for RALs. You're looking for hepatomegaly. The first speaker gave you a couple of multiple choice questions. This was one of the questions there. What do? You give your boluses, but you reassess right away. If you have access to ICU, you could give up to 60 cc's per kg of crystalloids in the first hour. If you do not have access to ICU and you're in a low resource setting, it is advised that you don't give more than 40 cc's per kg, in patients who have hypotension. I don't know if you remember the FIST trial. I'm just going to pull it up at some point and show it to you guys. Now, let's look at what the Surviving Sepsis Campaign International Guideline says. This is a very beautiful graph. The way that I want you to look at this graph is to look at the septic shock at the middle. And then on the left is the blue side, and on the right is your lemon green. But we're going to be talking about healthcare systems without intensive care. That's the lemon green on the right side. The blue side is healthcare systems with intensive care. But I want our focus. We're talking about low resource settings. So let our focus be mainly with healthcare systems without intensive care. So for healthcare systems without intensive care, what is important is to check if the child has hypotension or not. So if that child has abnormal perfusion, but without hypotension, do not give fluid boluses. The only time that you are allowed to, or you're recommended to do fluid boluses, is if there are signs of dehydration and there is an ongoing fluid loss. That is only when you're allowed to do boluses. Otherwise, start with your maintenance fluid, monitor hemodynamics, and then decide when to start your vasoactives. However, if the child is hypotensive and there are no signs of fluid overload, then you can start 10 to 20 cc's per kg of your crystalloids, and then you continue to assess your hemodynamics. If you have access to ultrasound or anything that you want to use to measure your cardiac function, you could do that. But as you're giving 10 to 20 cc's per kg, then you have to consider when you need to start your vasopressors right away. Now, what is important in these two lemon green bars is hypotension or no hypotension. If you look at this table, at the bottom of it is the red segment of this. It defines hypotension in healthcare systems without intensive care. Believe it or not, the definition of hypotension in this sort of setting is systolic blood pressure less than 50 in children who are less than 12 months is considered hypotension. Children who are between 1 to 5 years of age, hypotension is defined as systolic blood pressure less than 60. And then children who are greater than 5 years of age, hypotension is defined as systolic blood pressure less than 70. Now, there's another way to define hypotension based on the WHO criteria, which is the presence of all these three: cold extremity, prolonged cap refill, or weak or fast pulse. If you have all these three together, it is also considered hypotension. The reason why this is important is that it helps you on how you are going to give your crystalloids. Now, this is a very, very seminal paper. I'm not going to talk so much about it, but it's a paper that I would encourage all of you to take a look. It's a paper that is written by Dr. Maitland that talked about mortality after fluid bolus in African children with severe infection. Their conclusion is that fluid bolus significantly increased 48 hours mortality in critically ill children with impaired perfusion in some resource-limited settings in Africa. So be very careful. Be very careful how you give your crystalloids. And like we said, check for hypotension before you decide whether you're going to give boluses or you're just going to go with maintenance fluid. What about vasoactives? You are giving your fluid boluses, but you still have signs of shock. Then move right away. In the first hour, the golden hour, start your vasoactives. There are a couple of vasoactives that you could start depending on what you have in your region. You can start with epinephrine, you can start with norepinephrine, you can start with dopamine. I think in some places it's called adrenaline, noradrenaline, or dopamine. And our starting dose is usually 0.05 to 0.1. If you start that, then you begin to titrate your pressors depending. You can use your map. You look at your percentile, 5th to the 50th percentile for age, and then keep titrating. Or you could use your other clinical indicators. You could use your urine output. You could use your peripheral perfusion. For us, dopamine is good, but we are beginning to move away from dopamine because of the adverse effects that dopamine have. We usually prefer AP or non-AP. However, it depends on what you have in your region. The important thing is that whatever you have, start that right away. If you have started either epinephrine or norepinephrine, or both of them, and you're still having signs of shock, you're also recommended to start vasopressin if you have vasopressin. However, if you're starting vasopressin, please just know that you're also risking ischemia, mainly digital ischemia, so you need to watch out for those. Then in some areas where we have murinon, if you have murinon and you're still having persistent shock with evidence of low cardiac output, you could start murinon. However, if you're starting murinon, you have to be very careful that murinon could also worsen your hypertension. Now, what else do? You have to look at your respiratory support. Like I told you guys earlier, A, B, C, D. Just check and be sure. Supplement your oxygen. Then look at your patient. If he's having severe respiratory distress, but at least still having effective breaths, you can start with non-invasive positive pressure ventilation. Depending on what you have, you can start CPAP, you can start BiPAP. If the child is in complete respiratory failure, or the child is having altered mental status, or the shock has been refractory to all your initial management, you are recommended to intubate and mechanically ventilate those children if you have the resources. If you've decided to intubate and mechanically ventilate these kids, please be careful with your induction agent. The preferred induction agent for us is usually fentanyl and ketamine. The things that we would like to avoid are propofol and benzodiazepines. Propofol could cause massive vasodilatations and worsen your hypertension, and benzos could also cause some sort of myocardial depression. So if you have your fentanyl and ketamine, you better go with that. There is also a questionable risk of starting etomidate. Etomidate, even a single dose of etomidate in a febrile septic kid could cause adrenal insufficiency. So be very careful if you're going to do etomidate. What about antimicrobials? Antimicrobial therapy in the first hour is the most important, is the primary therapeutic intervention. And I'm going to say it again. Antimicrobial therapy is the primary therapeutic intervention for septic shock. Everything that you've done is supportive. IV fluid that you've given is supportive. Your vasoactives are supportive. The primary intervention is your antimicrobials. And I think I've said it enough. And the reason why I'm saying antimicrobial really in resource-limited setting is that it depends on what is causing the shock. It could be bacterial. For high resource setting, most times it's bacterial. For low resource setting, it could be anything else. It could be fungal. It could be parasitic. It could be rickettsial infection. But the important thing is that whatever that you've decided is the reason why the kid is in shock, start the antimicrobials. If it is bacterial, you're starting your antibiotics, broad spectrum antibiotics, by the way. You're starting that in the first hour. This is the golden hour. You start that in the first hour of shock recognition. However, the Surviving Sepsis Campaign Guideline of 2020 actually recommends to start antimicrobial within the first 3 hours of recognition of sepsis. If the child is not in shock yet, you have up to 3 hours to start your antimicrobials. I just want to quickly mention some of the general principles of empiric antimicrobial coverage. One is Because this is sepsis, because this patient might be in shock, do your dosage maximization. Go for the highest dose that is recommended. Now, if the child is immunocompromised and you have access to anti-pseudomonal agent, it's also advised that you do that. It is recommended that you get your cultures, but please do not delay starting antibiotics because you want to get cultures. And the moment you send your cultures and you get your result back, you can narrow the antibiotics. Some hospitals are beginning to do QI projects with antimicrobial stewardship. If that's what your facility has, that's also quite good. This is just a chart that gives you suggested empiric antimicrobial coverage in children with sepsis. I'm not going to go through that. On the left side is the clinical situation. On the right side is the antibiotics that you're recommended to start. Sepsis without a defined focus, ceftriaxone. I love ceftriaxone, is broad spectrum, So, but it depends. Just go through that and then make a decision on what antibiotics regimen that you're going to start. What about source control? You've started your antibiotics, but look for what is causing this infection. If it's a suspected indwelling catheter, that should come out. If it's an abscess, you're doing I&D right away. If it's a necrotic tissue, fasciitis, you're debriding. If it's a septic joint empyema, you're draining all those right away. Now, a good amount of these kids with sepsis will not grow anything on their culture, up to 30 to 75%. And we call this culture negative sepsis. Part of the explanation is that sometimes the host response that is giving you the septic picture is just a reaction of some of the endotoxins, or because you've started antibiotics before you collected your culture, you might have a culture negative sepsis. However, there are new molecular diagnosis techniques with PCR that are beginning to come out that we're beginning to use in high resource setting. It might not yet be available in the low resource setting, but these help us with bacterial identification. There are great mimics, what we call the hyperinflammatory conditions or autoimmune processes. Please, as you're treating, also have at the back of your mind that this could be one of the hyperinflammatory conditions like the HLH, the hemophagocytic lymphohistiocytosis, or your macrophage activation syndrome. Very important condition, catecholamine resistant shock. If you have given your fluid, you've started your vasopressors, you've given antibiotics, but you're not reversing the shock yet, it is advised that you start your stress dose steroid. While you're starting your stress dose steroid, please try to evaluate for some of these comorbidities. Check and be sure that the kid doesn't have pneumothorax, that the kid doesn't have pericardial effusion, that there are no intra-abdominal hypertension, no ongoing blood loss, and again, there is no occult infectious source that you have not identified yet. What are the other parts that we really need to talk about? Like I said, in catechol refractory shock, you're starting your stress dose steroid. The use of insulin for tight glycemic control is not recommended. If you have persistent hyperglycemia, and by that we mean hyperglycemia that is greater than 180, we have a broad range of normal glucose level for sepsis. It's usually from 80 to 180. So we are not going for tight control. You have a leeway, 80 to 180. If you're having persistently higher than 180, then you can start your insulin to bring it within this broad range. If your calcium levels are low, it is recommended that you optimize your calcium. Calcium is considered also as an ionotrope. If your magnesium is low, you also recommended to replace your mag, but be very careful. Magnesium by itself would also worsen hypotension. Hemoglobin threshold for kids who are hemodynamically unstable is recommended to be about 9 or more for those that are hemodynamically unstable. If they are hemodynamically stable and there are no bleeding, it's recommended that you maintain your hemoglobin at about 7. In DIC with active bleeding, not just DIC, but DIC and then the kid is bleeding, you're recommended to replace your platelets, give fresh frozen plasma or cryo, depending on what is causing your DIC. Currently, there is no evidence to recommend prophylactic transfusion, even when a kid is coagulopathic, except that kid is bleeding. What about advanced therapies? There are 2 major advanced therapies for most centers in low resource setting, you might not have this, but if you do have, the first one is your continuous renal replacement therapy. This is not recommended for routine use. However, if you have the resources and the kid has fluid overload that has not responded to our standard therapy, then you can start your CRRT. If there's acute kidney injury, you can start your CRRT. If there's persistent lactic acidosis, you could also do that. Finally, extracorporeal membrane oxygenation. If you have the resources, if you have it available, and you're having failure of your conventional respiratory support or failure of your conventional cardiac support, you are recommended to start ECMO for appropriately selected patients in an area that has resources to ECMO. Starting ECMO early enough increase survivors to greater than 50%. And the ECMO mode that we usually recommend is your VA ECMO. So in conclusion, I've just very quickly mentioned about the international consensus criteria for sepsis and the septic shock. I told you that this was an outpouch of the sepsis 3. We talked about the Phoenix criteria that in suspected sepsis with greater than 2 points on our Phoenix score is how you define sepsis. And we talked about the management of pediatric sepsis. I kind of emphasize so much on your initial A, B, C, D, and then your fluid, your vasoactives, your respiratory support, your antimicrobials, and then looking for vasoactive refractory shock. And I also mentioned the Surviving Sepsis Campaign international guideline for management of septic shock and sepsis-associated organ dysfunction in children. Thank you so much. It's been my pleasure, actually, to be part of this webinar, and I'll be happy to take any questions.
Thank you, Dr. Nwankwo. I think that you all can see why Odira is such a highly regarded educator, and like all excellent educators, they generate a lot of questions. I don't know what our time constraints are now, Dr. Husseini.
Maybe 5 minutes more.
Sure. I mean, Odira, a wide range of questions dealing with just the sort of the Phoenix criteria to more practical issues. Maybe if you wouldn't mind, it seems if I could maybe summarize a number of the questions dealing with these criteria, Odira, from their use as predictive versus diagnostic versus screening tools. I think this is something that many of us struggle with, and it seems like some of our learners, for example, the utility of the Phoenix criteria, we recognize it as a diagnostic tool, but its power as a screening tool and then also as a predictive tool. You have any insights into that?
Yeah, thank you so much, Michael. So the emphasis on Phoenix definition is on diagnostic and management. It's not for screening at all. The encouragement really is for individual hospitals to still continue with their screening tools for identifying early sepsis. But the Phoenix zeroes in mainly for diagnosis and management. I don't know if that answers your question.
Yeah, I think that's an important notion. I think that was brought up earlier by Dr. Sedek, and I think that so we use it to diagnose sepsis, but it's not its power is not as a screening tool. And I do think that there's data that higher scores are predictive of mortality, but this is a different function entirely. So that's a great distinction. There are some practical questions like, Odira, how does one define catechol-resistant sepsis? I think all of us have a kind of our own little definition. I know what mine is. What is yours?
So excellent. So what is important really is, like I said, in the golden hour, you've done your IV fluids, you're starting your catecholamines, but you have to keep reassessing your kid. If you've given your fluid boluses and you've given the catecholamines, you're like on 2 or 3 of your pressors, and you have not reversed your shock. It could be an overt or a clear, some sort of absolute or relative adrenal insufficiency. It does not really matter. If you have maxed out on your vasoactives, it's considered refractory. And at that point, you're actually allowed to start your stress dose steroids.
Thank you, Odira. And the issue of cortical illness related adrenal insufficiency is a question that still remains unanswered and is being explored. So hopefully in the next couple of years, we'll have even more insight as to whom and when we should use corticosteroids, but I think that most of us commonly use them after our second vasopressor if the patient is unresponsive. And I think there's one other question maybe you could address, Odira. It has to do with one of the questions in the box that was related to, since hypotension is a late sign in pediatric sepsis, and is a component of the criteria that we're now using, would you wait for treatment? And this sort of gets to the question of the screening tools you're using, et cetera. So I think I know what you're going to say, but perhaps you can take over.
Oh, yeah. Thank you so much, Michael. So it's actually very interesting that the Phoenix sepsis score has the hypotension. But remember, in the cardiovascular component, there are three, actually. You have your vasoactives that you could do, but in instances where you don't have access to doing your vasoactives and you can't look at your lactate, that is the only time that you are allowed to look at blood pressure. However, in pediatrics, we do not wait. There are other organs that you can look at. You can look at your CNS, you can look at your respiratory, you can look at your coagulation. Do not wait. By the time that child is hypotensive, you're in trouble. You know, it's almost like a child falling off the cliff. So do not wait to have hypotension before you act.
Thank you, Odira. I mean, I think that's a common theme for all of our speakers today, and that is the recognition, the early recognition and intervention in sepsis is the probably the single greatest thing we can do to reverse the process. So I think that's probably all that we have time for. Odira, always a pleasure. Thank you. And I'm gonna step back.
Thank you so much, Michael, for your moderation. And thank you so much, Dr. Odira, for your presentation. And I'm wondering, we still have more than 400 attendees in the meeting. Actually, we didn't lose any significant number. I was wondering, we are almost running for 1.5 hours. I will give a couple minutes for Dr. Raed Sadek to give a closing remarks and take-home messages. And please, if you are interested to join our fellowship, we already added the fellowship landing page and also the registration and the application links in the chat box. And if you are interested, please, you can use the discount code for 10% discount, and this will be expired in a couple days. So please go ahead and do it. The 10% discount code is webinar 10. And now Dr. Wright is going to give us the closing remarks.
Okay, thank you, my colleagues, for this really amazing illustrations. The closing remarks, I will just put this table comparing the pediatric 2005 sepsis criteria and the 2024 Phoenix criteria. This is simply a SARS-driven, this is organ dysfunction-driven. There is, in the 2005, there was a spectrum of disease, sepsis, severe sepsis, septic shock. So in Phoenix, there is only sepsis and septic shock. There is no more for this really ugly terminology. SARS actually mainly depends on the vital signs plus minus organ dysfunction. However, Phoenix clearly depend on organ dysfunction and use the 4-organ system. Fluid refractory hypotension and the use of vasoactive use for the cardiovascular septic shock. However, in the Phoenix, only one or more cardiovascular point plus the Phoenix 2 points for sepsis. 2005 was only expert consensus. However, Phoenix criteria, it is a global data. The data it was derived from almost over 3 million encounter, and it is associated with really predicting the mortality in pediatric sepsis. So the Phoenix advantage is, as I mentioned, just now that it is high mortality correlation. So children scoring 2 or more, they have 8 times higher mortality risk than the general infection in cohorts. It reduced the overdiagnosis, as I mentioned, some cases that labeled like bronchiolitis, DKA, or viral infection. can be labeled by SARS criteria as sepsis, so it will remove this overdiagnosis. However, maybe its limitation that it can it can it can miss early diagnosis of sepsis, and especially if you depend, as we just mentioned, about the blood pressure, not using the tachycardia. So I think still maybe we can use SARS criteria as a screening, especially in resource setting. Definitions of PHENIX assume bacterial sepsis. However, it may miss specific infection like malaria or dengue fever that needs special treatment, as even Dr. Daria mentioned about malaria shock. The too much fluid will be detrimental. Using so this is very important. I think also we can keep it in mind that we use PHENIX for mortality risk stratification, but we can use SARS for early screening, especially in the emergency settings. We should use the resource adapted approach that in low resource setting, as we mentioned, that you can tailor your markers. If you just have platelet, you can use it and use your clinical judgment. Very important that PHENIX applies for children more than 37 weeks post-conceptional, so neonates should be separated from this definition. And the last point, that the PHENIX criteria represent a big model shift toward precision. However, please don't forget your clinical judgment, which is essential. Thank you.
Thank you so much, Dr. Wright, for this nice summary. And we are closing here, and I just want to give some take-home messages. Dr. Chigan Ersen from South Africa, he sent in our WhatsApp group the executive summary of the Surviving Sepsis Campaign, the international guidelines for management of septic shock and sepsis-associated organ dysfunction in children. So please try to have time to read this executive summary. The other thing I want also to share with you today is don't miss this opportunity if you haven't done it yet, and join our fellowship with a discount code, 10% discount code of webinar 10. Here are the links. The last announcement I want to make is our next webinar will be on Tuesday, July 22nd, and it will be focusing on IV fluid management and resuscitating septic children and hemodynamically unstable children. So please mark your calendar for Tuesday, July 22nd. And with that, I really appreciate your presence, all the attendees' presence, and your patience for more than 1.5 hours. And of course, our moderator, panelist, and speaker. And see you next month. Thank you.